Hello everyone, Saud Al-Zaid here and welcome to the latest episode of The Surge. Today I want to talk about ICU rounds at the bedside and how we could do them better. I was recently introduced to rounding in the ICU here in Kuwait, and it got me thinking as to how good are we at this internationally and how useful are interdisciplinary rounds involving nurse, doctor, RT, pharmacist, nutritionist, etc. And are there any key tools or key points that we should concentrate on? Is there a turnkey solution available? Is there a one-size-fits-all strategy that we can follow and conform to? And how could we do it better is basically what I'm trying to talk about today. So, are we any good at this? Predictably, probably not. It's estimated that we talk to the nurses 1 in 10 times, 12% of the time. We involve ourselves in physical examination about 14.6% of the time. And we talk about evidence-based topics 7.2% of the time. So this problem's probably been there for a while. It will probably be there for a long time to come. And as this study in 2013 showed, no matter how good you are, you'll still be abysmal at it. Apparently. And this is something that has sort of been reinvestigated over the years, and it's been found to occur in almost every center. We're all just as guilty as each other at not providing optimal teaching at the optimal time. And it seems that there are certain risk factors, if you want to call them that, for suboptimal interdisciplinary rounds. Putting it mildly, things like having a senior resident around, it being a weekday, and having a younger attending physician around led to more bedside teaching, and having a more experienced physician with longer years of experience and longer weekdays did have longer rounding times, but not significantly better rounds, where better is defined as more evidence-based teaching, more resident-driven discussions, etc., and more nursing and multidisciplinary involvement. So there seems to be seems to be an international problem that even transcends the ICU and seems to occur all over the place. And one thing that everybody can agree upon is that we need to be able to do it well and do it better, and that by doing so, we provide a better working environment. This is one of the first descriptive studies to take a look at that and to take a look at what might be optimal in terms of care planning. And it seems that as a consensus, we're looking for nurse and MD driven rounds that outline long-term goals and short-term goals over 24 hours, and that allow patients to participate in the decision making where possible. But are these rounds actually useful? And it turns out that they are. Not only do they lead to better satisfaction in terms of people working in the ICU, both the doctors and the nurses, but also they seem to point towards shorter length of stay, less time to consultations being put in, and better operational structure in the overall scheme of things, because it seems that there's a unified plan involved. Nursing attitudes towards these rounds have historically been very positive, but in places where it has occurred, it's only been shown that 50 to 60% of nurses see a viable improvement in terms of patient care on the ground and at the bedside. And I think that part of it is the fact that we're not executing them all that well. And another argument for that is the fact that over the past, I'd say 5 or 6 years, there have been 2 Cochrane reviews, one of them looking at interventions to promote collaboration between nurses and doctors, and the other one looking at the effects of practice-based interventions on professional practice and healthcare outcomes, i.e. how should we go about improving our integrated system and what outcomes should we look at. And both reviews seem to be fairly non-conclusive. We don't have any straight answers, which leads me to believe that this could be one of 2 things. There could be one of 2 reasons. Intuitively, descriptively, it makes sense that integrated rounds should lead to better outcomes. I think that the first reason why we haven't proved that yet is the fact that there are so many variations in practice. This is just a study out of a single county and Pennsylvania, single state, Pennsylvania. And as you can clearly see, there's such a heterogeneity of practice that there's no way you can come to a clear conclusion as to whether or not an intervention would work there, especially an intervention as nuanced as rounds, the cornerstone of patient management in 2017. So in conclusion, I mean, there are only two things that I can conclude from these papers and these studies. The first is that anything's better than nothing. So any type of nursing plan or goal-oriented initiative with the view that nursing and doctors should be involved as joint decision makers in the management of patients is a good thing. And that one size does not fit all, and that there's a variability of practice that has to be factored in somehow. And you have to figure out where to start. And a good place to start seems to be the use of a daily goals checklist, something as simple as a written piece of paper that says what we're going to do today. And this is just one example of one that has been validated, called the ICU Daily Goals Checklist and Plan of Care. And this was published and endorsed by the Society of Critical Care Medicine fairly early on, and seems to be the standard in many ICUs and institutions, including Hamilton Healthcare. And it goes through the biggest and most important decision-making points, I think, with nursing pre-rounds and doctor rounds or MD-driven team rounds, having specific aspects of weaning, ventilation, infection prevention, control, fluid status, access line sites, comfort, sedation, labs and procedures, medications, psychosocial concerns, research, consultations, etc. My only problem with this checklist is that very few people filled them out in the end, particularly the MDs. And the MDs who were filling them out were non-certified hospital doctors or residents or NCHDs, depending on which side of the Atlantic you live on. So it wasn't exactly a fully validated study. But it did show that there has been some improvement in the way that we communicate, some improvement in time to consultation, and things like that. Putting that checklist on a computer didn't help things much, especially because in this study by the certain group who's trying to develop a content management system with point-of-care decision-making support, basically making the computer make the decisions for you or help you to remember, if you want to call it that, to make a decision. I'm not a very big fan of these systems, but it seems that this one actually works. And a pediatric version of it has recently come into the wild about a year ago, and I'm not going to lie, I like the idea of having a checklist available to me during rounds so that I don't forget anything, but at the same time I don't like the idea that a machine will eventually start to make decisions for me, or that I'd have to justify decisions that I've made independent of the machine. I think it's early days, so some cognitive and some intuitive thinking still involved in running an ICU. But if you're looking at the way of the future, this seems to be it. Although I have to say that all the studies that looked at this up till this point, from my knowledge at least, or to my knowledge, the ones that I've come across basically, have not been very convincing. They report excellent user experiences, but they don't report any positive patient outcomes at this point. So I wouldn't hold your breath if you're looking for something like this to drag around with you during rounds. In terms of what works best in terms of a checklist, because there's so many different variations in the literature, one thing that all studies seem to have concluded is that the more explicit the checklist is and the more simple it is, the better. This is just a study out of the American Journal of Medical Quality from 2015, and it just compares a random goal set type of situation to a systems-based approach, and they found that it was more clear definitive communication, and the time to reaching the goals was improved as well, which is quite interesting. So basically, if we all agreed that this is what we want to do today, and we all have a limited number of choices as to what we can do on any given day, we tend to do it better. The reality is that all of these studies collectively are trying to mirror crisis resource management models from the aviation industry. And I don't think that that's the right place to start. This isn't a patient problem. This isn't a crisis resource management problem. This isn't an economical problem. This is pure and simple system design. And, when I sat down and I tried to figure out what would work best for my institution, at least, I found that the doctor versus nurse model that everybody keeps reporting in the literature doesn't exist in 2017, at least not in our institution here in Kuwait. We tend to have discussions between us, nurses, respiratory therapists, pharmacists, even nutritionists most days. And I apologize for putting MD up there first. RTs should go up there first, and then pharmacists next. So it's an equal opportunity, a list of people that are involved in 2017. And that the fact of the matter is the decisions that we make during rounds are based on status and goals, as opposed to who gets to talk and who doesn't, or who's involved and who isn't. Whoever's there and whoever is available and whoever's not too busy will come and voice a concern whenever they have to, and that's just the way that our institution runs. So for me to do something like the intricate Hamilton super checklist is extremely, extremely difficult and non-viable, at least in our institution. And, whenever we make a decision here, we tend to have to feed it forward and feed it back to other members of the team. So the reality is we're not really designing a checklist, and it's not that we're trying to make things more or less goal-oriented. We're actually designing rounds. And when you design rounds, you have to look at your patient population, you have to look at the people who you're working with and their abilities, and then you have to look at what you bring to the table. In our institution, the policy that we're trying to apply is this one, and I will provide you with JPEGs of them as well. We follow systems-based approach because that's the way that we document everything in our unit. We begin by talking about GCS, or regiment agitation, depending on the burden of injury and type of patient that we have. The sedation type and whether or not a sedation holiday is appropriate, and this is a discussion that occurs at MD and nursing level. There are certain things that we expect from our residents as well, to talk about the latest plan from the other members of the team that may be involved with traumatic brain injury or CVA in our patients. We also talk about cardiovascular problems, lines, the dates that they're put in, the nature of the sites, whether it's clean or looks infected, any vasopressors, tropes, or vasoactive agents and what the trends are, and any episodes to changes in blood pressure, heart rate, or central venous pressure over 24 hours. We also talk about our ventilation strategy, any improvements or deterioration, VAP measures and elevation of head of bed, etc. I get my RTs to talk about whether or not a patient has frequent suctioning, the type of suctioning that's done. Is there any difficulty if it's a fresh intubation? And if it's somebody who's been intubated for a week, then I like to talk about lung mechanics, if and when we have time to do them. Our MDs have a responsibility to check the chest x-ray before rounds, let us know about them. They decide on the weaning goals for the day and decide on the need for a tracheostomy. In terms of GI, we talk about the need for NG feeding, if the NG is in the right place and confirmed, any wounds or drains, and any bowel motions. We also talk about the need for stress ulcer prophylaxis, enteral feeding, parenteral nutrition, laxatives, and prokinetic agents. We then move on to talking about overall fluid balance, the renal system, any signs of renal failure, and IV fluid replacement strategies. We talk about our latest set of labs and whether it's appropriate to continue our lab testing strategy on a regular basis or not if a patient's more chronic and has been in the ICU for a while. We talk about our cultures and the need to stop antibiotics as soon as we can. And then we talk about insulin, blood sugar control, and other endocrine factors, as well as a pharmacy review. We then move on to any reported bed sores. And then we talk about how we're going to communicate with other people in the hospital and how we're going to divide up that work and who's going to be talking to the family, whether it's a nursing day, an MD day, or an attending day. We talk about that as well. And then we confirm everything in summary before we move on to the next patient. Now, this is just the front of the sheet. The back of the sheet is sort of like a small reference sheet for the newer, more junior members of the team, so that they have a bunch of parameters that may not be commonly reviewed, but you would need to know from time to time. So in conclusion, design your rounds based on what you need. It's not one size fits all, but what the literature has proven, or I wouldn't use a word as strong as proven, but what the literature supports is a strategy where you have some sort of structure when you reach a patient's bedside, and a strategy where everybody feels like they're contributing and that they're on the same page. So I think that no matter what you do at this point, nobody will fault you, but you have to have some sort of a checklist or a structure. And I'm not saying to use mine. I mean, heaven knows it's not really validated, but have some sort of structure in mind. This is Saud Al-Zaid signing off, and please subscribe, and thanks for listening.